Welcome, curious minds, to the deep dive. Today, we're going to pull back the curtain on a world we rarely see, but one that, well, profoundly impacts every single one of us. Talking about the microscopic battleground of infectious diseases. It's this whole universe, teeming with tiny invaders and our body's amazing defenses, a constant high-stakes dance between triumph and challenge.
It really is. I mean, think about it from the common cold that just trips us up for a few days to, well, devastating global pandemics that completely reshape societies. Understanding how these unseen forces operate is it's really key.
That's right. And our mission with this deep dive really is to give you a shortcut, a way to get truly well-informed about this incredibly complex topic. We've basically distilled years of specialized knowledge, drawing from this really comprehensive set of expert-level medical sources, all into one, hopefully engaging conversation.
Yeah, the goal is for you to walk away not just informed, but genuinely fascinated, and hopefully without that feeling of being totally overwhelmed by all the information.
Exactly. Think of it as maybe a guided tour through the most critical bits of infectious disease knowledge, pointing out the surprising facts and the practical insights that actually matter.
Okay, let's dive in then.
All right, let's unpack this enormous topic. We'll try and pull out the most compelling details, maybe some unexpected connections. So if we're really diving deep into this microscopic battleground, where better to start than the command center, the brain itself? It's terrifying to even think about. But the brain under siege, that's a very real thing in infectious diseases. Some of the most urgent, most complex battles happen right there.
Absolutely. And when we talk about central nervous system infections, bacterial meningitis is probably the prime example of urgency. We're often taught to look for that classic triad of symptoms, fever, stiff neck, altered mental status. But the real insight here, and what clinicians really grapple with, is that less than half of cases, maybe 45%, actually present with all three.
Wow, less than half.
Yeah. Which forces doctors to act incredibly fast with a really high index of suspicion, even if they don't have all the pieces of the puzzle yet. Because waiting for that perfect diagnosis, it can literally cost lives.
That's a vital point. Almost counterintuitive, really. So acting fast, even before all the diagnostics are back, is absolutely critical. What are some of those key tools doctors lean on for these brain infections?
Precisely. Lumbar punctures are crucial. Analyzing the cerebrospinal fluid, that's the fluid bathing your brain and spinal cord. We look at cell counts, protein, glucose levels. They give us clues. But what's important to remember, even with bacterial meningitis, the Gram stain, which can quickly identify bacteria, it can actually be negative in up to 50% of cases.
Half the time?
Yeah. Which, again, just goes to show why you need that empiric treatment, starting therapy before you have all the results.
Right. So you're starting treatment based purely on strong suspicion. What about more specific invaders, viruses, for example?
Well, take herpes simplex encephalitis, HSV encephalitis. This viral infection, it often causes confusion, maybe seizures, and localized damage, typically in the brain's temporal lobes. And here, PCR testing of the CSF has been a game changer. It's incredibly sensitive, very specific.
So it avoids more invasive tests?
Exactly. It's largely replaced the need for a brain biopsy, which used to be the gold standard. The absolute key takeaway for HSV is early and continued intravenous acyclovir. Any delay just dramatically worsens the prognosis.
Okay. And West Nile, that can cause paralysis, right?
It can, yeah. West Nile neuroinvasive disease can cause this sort of polio-like paralysis. For that, CSF serology, specifically looking for IgM antibodies, that's the preferred diagnostic test.
It's really incredible how precise those modern diagnostic tools have become for things like herpes and West Nile. But thinking about the brain, are there any truly, unusual or maybe insidious invaders that stand out? Maybe because of how they work or some surprising connection?
Oh, definitely. Then you have prion diseases like Creutzfeldt-Jakob disease, CJD. These are really rare, thankfully, but just devastating because they're not caused by typical germs like bacteria or viruses.
Right, they're different somehow.
Totally different.
Yeah.
Imagine a protein in your brain, normally folded just right, suddenly getting, misfolded, squished into the wrong shape. And then, like dominoes, it forces other normal proteins nearby to misfold too. This process creates tiny holes, vacuoles, in the brain tissue, eventually making it look spongy under a microscope.
Wow.
And while it often happens spontaneously, just out of the blue, it's fascinating and, a bit unsettling that historically some forms could even be transmitted through things like contaminated surgical instruments or famously linked to eating infected beef, the whole mad cow scare.
That's a chilling thought, a protein itself causing that kind of damage. What about that autoimmune condition you mentioned, the one that's more recently understood?
Ah, yes, anti-N-methyl deaspartate receptor encephalitis, or anti-NMDA receptor encephalitis. It's this fascinating autoimmune condition that often presents with just a bewildering mix of psychiatric symptoms, psychosis, agitation plus seizures, and sometimes these really bizarre involuntary movements.
Sounds incredibly difficult to diagnose initially.
It can be, but what's truly surprising and clinically so important here is its strong link to ovarian teratomas, a specific type of tumor in over half the patients, particularly young women.
A tumor causes brain inflammation. How?
Well, the thinking is that the immune system starts attacking components of the teratoma, which happen to look very similar to proteins found on nerve cells in the brain, specifically the NMDA receptors. So the immune system gets confused, essentially, and mistakenly attacks the brain itself.
Rah.
And the treatment reflects that. You need to remove the teratoma if one is found, and then use immunosuppressive therapies, things like steroids, IVIG, or rituximab, to calm down that misguided immune attack.
That just highlights how incredibly interconnected everything is. A tumor somewhere else causing a brain-on-fire situation. Amazing.
It really does. Shows how complex these immune-related diseases can be.
Okay, all right. Let's broaden our view a bit then, beyond the brain. Let's talk about skin, bone, and beyond. Our body's protective layers, our structural supports. They're also really common targets for infection, right?
They absolutely are. Take common skin infections like cellulitis, for example. A key distinction right away is whether it's purulent or non-purulent.
Meaning pus-filled or not.
Exactly. If it's purulent, meaning there's pus or maybe a drainable abscess, your prime suspect is often MRSA, methicillin-resistant Staphylococcus aureus. Non-purulent cellulitis, on the other hand, that red spreading rash without significant pus, that's typically caused by streptococcus.
Okay, so that difference guides treatment.
It guides your suspicion and initial treatment, yeah. For simple skin abscess, the main treatment is actually incision and drainage, I&D. Basically, opening it up to let the infection out. Antibiotics are usually added if the abscess is large or if the patient has signs the infection is spreading systemically, like a fever, or if they have other risk factors, very young, elderly, weakened immune system, that kind of thing.
Got it. So whether there's pus is a big clue. What about those really severe, like limb-threatening skin infections that need super fast attention?
Right, you're probably thinking of necrotizing fasciitis, often called flesh-eating bacteria, though that's a bit dramatic. But it is a life-threatening emergency. The hallmark sign, and this is really crucial for anyone to know, is pain that seems way out of proportion to how the skin actually looks.
Pain out of proportion.
Exactly. The skin might not look that bad initially, maybe just a bit red or swollen, but the patient is in excruciating pain. Other clues are rapid spread, maybe some dusky or purplish skin discoloration, and potentially these hemorrhagic blisters.
Scary. What's the key to survival?
Speed. Early aggressive surgical debridement, getting into the operating room quickly to remove all the dead and infected tissue, is paramount. That's alongside broad-spectrum empiric antibiotics that cover a whole range of bacteria, definitely including MRSA coverage up front. If it turns out to be Streptococcus pyogenes, which is a common cause, a combination of penicillin and clindamycin is often preferred. The clindamycin is thought to help by shutting down the bacteria's production of harmful toxins.
That pain out of proportion clue really sticks with you. Okay, shifting focus slightly, let's talk about our body's framework. Bone and joint infections, osteomyelitis.
That sounds like it could be a really long battle.
It certainly can be. Osteomyelitis, that's infection in the bone, it requires really precise diagnosis. Usually this means getting a bone biopsy for culture. You need to know exactly what bug you're fighting.
Unless blood cultures already found it? Right. Unless blood cultures are already positive for a likely pathogen, then maybe you can skip the biopsy. Imaging like MRI is very sensitive for detecting bone inflammation, but it's not perfectly specific. Interestingly, a draining sinus tract, where pus is actively weeping out from the skin overlying the bone, that's actually considered pathognomonic for chronic osteomyelitis, it basically confirms it.
And the treatment is long.
Very often, yes.
Yeah.
It usually involves surgical debridement to clean out the infected bone, followed by prolonged antibiotic therapy. We're talking 6 to 8 weeks typically, sometimes even longer, especially for tricky situations like diabetic foot osteomyelitis after surgery.
Wow, that's a serious commitment.
It is. And for joint infections, septic arthritis, the key is to aspirate the synovial fluid, the fluid inside the joint, and get it cultured. Again, Staphylococcus aureus is the most common culprit for bone infections that spread through the bloodstream.
Okay, that really highlights how deep these infections can get. Let's move now to our internal systems, respiratory and gut invaders. Pneumonia is just a massive global health concern, isn't it?
It absolutely is. Pneumonia remains a leading infectious cause of death worldwide. A really crucial first step is differentiating between community-acquired pneumonia, or CAP, pneumonia someone catches out in the world,
Right.
versus hospital-acquired pneumonia, HAP, or ventilator-associated pneumonia, VAP. That distinction matters hugely because the likely bacteria involved, and therefore the initial empiric antibiotic choices, are significantly different.
So where you got it changes the likely bug.
Precisely.
Hmm.
And for severe CAP, the kind that lands someone in the hospital, we often recommend getting sputum and blood cultures to try and pinpoint the specific organism causing the trouble.
And what about those particularly stubborn bacteria, the multi-drug resistant ones we hear about?
Yes. A major concern there are the ESBLs, that stands for extended spectrum beta-lactamase producing organisms. Think of a beta-lactamase as sort of a molecular defense shield, or maybe a weapon that some bacteria develop. It allows them to break down and inactivate many of our most common and effective antibiotics, the beta-lactams like penicillins and cephalosporins.
So they just chew up the antibiotics.
Pretty much, yeah. And ESBLs are particularly worrying because they can neutralize a broad spectrum of these critical drugs. This makes infections caused by ESBL producers incredibly difficult to treat. They pose a real threat to our antibiotic arsenal.
So what works against them?
Well, even if lab tests, the susceptibility reports, suggest they might be sensitive to certain other antibiotics, a class of drugs called carbapenems, things like meropenem or imipenem, are often the only reliably recommended treatment for serious infections caused by these resistant bugs.
Okay, so they're like super resistors needing the big guns. Beyond bacterial pneumonia, what about things like tuberculosis? Still a big issue, right?
Definitely. Tuberculosis, TB, remains a major global health problem, especially affecting vulnerable populations. Diagnosis often starts with screening tests like the skin test or the blood tests, the IGRAs, which look for an immune response to PB. But to diagnose active TB disease, you need to find the bacteria. That usually means testing sputum samples using microscopy for acid-fast bacilli, and also doing cultures and molecular tests.
And the treatment is long, too.
Yes, treatment for active TB typically involves taking multiple antibiotics for several months. It's a huge commitment for patients to stick with it. And for individuals living with HIV, another type of mycobacterial infection, Mycobacterium avium complex, or MAC, becomes a concern, particularly when their immune system is severely weakened, typically when their CD4 cell counts drop below 50.
Fascinating how the immune status just opens the door for different infections. Okay, let's switch gears from the lungs down to the gut. Food poisoning and infectious diarrhea. What are the main culprits here, and how do we sort of tell them apart?
Right, foodborne illnesses can present quite differently. And yeah, understanding those patterns helps narrow down the likely cause. If vomiting is the main symptom and it comes on really fast, like within just a few hours of eating the suspect food, that often points to preformed toxins produced by bacteria like Staphylococcus aureus or Bacillus cereus.
So it's the toxin in the food, not the bacteria growing inside you.
Exactly. The bacteria already made the toxin in the food before you ate it, and that toxin hits you fast. Watery diarrhea, on the other hand, could be from something like Clostridium perfringens, or maybe norovirus, which is, notorious for causing those widespread gastroenteritis outbreaks on cruise ships or in schools.
Oh yeah, norovirus is rough.
It is. Then you have inflammatory diarrhea. This often presents with blood or mucus in the stool, usually accompanied by fever. This suggests more invasive bacteria are involved, things like Salmonella, Shigella, or Campylobacter.
And for travelers who get hit with bad diarrhea.
Yeah, for travelers' diarrhea, especially if it's moderate to severe, certain antibiotics can be appropriate. Depending on the region and resistance patterns, drugs like fluoroquinolones, azithromycin, or rifaximin might be used.
Okay, so the timing, the type of symptom vomiting versus watery versus bloody diarrhea are all important clues. Now let's delve into intimate and common tracts, thinking about sexually transmitted infections, STIs, and also urinary tract infections, UTIs.
Okay. For STIs that cause genital ulcers, a really key first step in diagnosis is figuring out if the ulcers are painful or painless. It's a major branching point.
Painful versus painless.
Okay. Painful ulcers typically make you think of herpes simplex virus, HSV. That often presents as small, sometimes grouped vesicles, little blisters, that then break open into shallow, painful sores. Or, less commonly now in many places, painful ulcers could be chancroid, caused by Haemophilus ducreyi. These tend to be larger, deeper ulcers, often with really swollen, painful lymph nodes, in the groin suppurative inguinal adenopathy.
And the painless ones.
Painless ulcers, classically a single firm, clean-based chancre that's the hallmark of primary syphilis. And then there's lymphogranuloma venereum, or LGV. This is caused by specific strands of Chlamydia trachomatis. It might start with a small, often unnoticed painless ulcer, but then progresses to cause significant painful swelling of the lymph nodes, which can sometimes rupture and drain. These are called buboes.
That pain distinction is such a critical fork in the road for diagnosis. And you mentioned syphilis. The treatment for that really needs to be tailored to the stage, doesn't it?
Absolutely. It's crucial. For early syphilis, that includes primary, secondary, or early latent syphilis, diagnosed within the last year, a single intramuscular shot of long-acting benzathine penicillin G is usually curative.
Just one shot.
For early stage, yes. But for latent syphilis, infection for over a year or unknown duration, or tertiary syphilis, affecting organs like the heart or skin, it typically requires 3 weekly doses of penicillin G. The bacteria are more established, harder to eradicate.
And if it gets into the nervous system?
Neurosyphilis, yeah, where the infection involves the brain or spinal cord, that's a whole different level. It requires high-dose intravenous penicillin, usually for 10 to 14 days. And if a patient with neurosyphilis is allergic to penicillin, they often need to undergo desensitization. Basically, carefully reintroducing penicillin in a controlled setting so they can tolerate this absolutely essential treatment.
That shows how critical penicillin still is for syphilis.
It really is. Oh, and it's also important to know about the Jerisch-Herxheimer reaction. This is an acute, temporary, flu-like reaction fever. Chills, headache, muscle aches that can happen within hours after starting syphilis treatment.
So it's not an allergy?
No, it's thought to be caused by the release of components from the dying Spirochetes, the syphilis bacteria. It's generally managed supportively with rest and maybe anti-inflammatories. While it can be uncomfortable, it's actually a sign the treatment is working. You just need to warn patients about it.
That's good to know what reaction that means it's working. Okay, shifting to urinary tract infections, UTIs. They seem incredibly common, especially for women.
They are extremely prevalent, yes. UTIs range from uncomplicated cystitis, which is basically a bladder infection, to the more serious pyelonephritis, which is infection up in the kidneys. For uncomplicated cystitis in women, a short course of antibiotics, maybe 3 to 5 days, is usually enough. Drugs like nitrofurantoin or trimethoprim sulfamethoxazole are common first choices.
And kidney infections need longer treatment.
Generally, yes. Pyelonephritis involves the kidney tissue itself, so it requires a longer course of antibiotics. Often 5 to 7 days for uncomplicated cases treated with fluoroquinolones, or maybe 10 to 14 days for other agents or more complicated situations. Fluoroquinolones are often preferred for outpatient empiric therapy if local resistance patterns allow.
Are there special groups you have to think about differently, like pregnant patients or people who get UTIs all the time?
Absolutely. 2 key groups. First, pregnant patients. Asymptomatic bacteria, just having bacteria in the urine without any symptoms, must be screened for and treated during pregnancy.
Even with no symptoms, why?
Because it significantly increases the risk of progressing to pyelonephritis later in pregnancy, which can be dangerous for both the mother and the baby. Simple antibiotics like amoxicillin or nitrofurantoin are often used safely. The second group is women with recurrent cystitis, which is unfortunately quite common, usually defined as 2 or more infections in 6 months or 3 or more in a year.
Right. What can be done for them?
For them, low-dose antimicrobial prophylaxis can be very effective. This might involve taking a low dose of an antibiotic daily, or perhaps just taking a single dose after sexual activity, which is often a trigger. This is usually tried for about 6 months initially to try and break that cycle of reinfection.
It's amazing how treatment has to be so tailored to the person in the situation. Okay, next up, let's navigate the world of hospitals' hidden threats, healthcare-associated infections, HAIs. These seem like a constant battle inside hospitals and clinics.
They truly are, and they pose unique challenges because, well, patients in hospitals are often sicker and more vulnerable to begin with, and the bacteria circulating in healthcare settings can be more resistant to antibiotics. Catheter-associated bloodstream infections, or CLABSIs, are a major one. Often linked to central venous catheters, those IV lines that go into a large vein in the neck, chest, or groin.
What's key to preventing those?
Strict sterile technique during insertion is paramount, using maximal barrier precautions, gown, gloves, mask, large drape, and meticulous skin disinfection with chlorhexidine, plus careful site care afterwards. If a CLABSI does happen, especially with certain bugs like Staphylococcus aureus, Pseudomonas aeruginosa, or fungi like Candida, the catheter itself almost always needs to be removed. It acts like a foreign body, a surface where bacteria can form biofilms and hide from antibiotics. Removing the source is critical, alongside giving the right systemic antibiotics.
So the line itself becomes part of the problem. What about infections linked to breathing machines, ventilators?
Right, ventilator-associated pneumonia, or VAP. This typically develops 48 to 72 hours after a patient is intubated. You look for signs like new or worsening fever, purulent secretions coming from the breathing tube, and worsening oxygen levels, often with new changes on the chest X-ray.
What kind of bugs cause VAP?
Common culprits include MRSA and resistant gram-negative bacteria like Pseudomonas aeruginosa or Acinetobacter species, especially in patients who've been ventilated for a while or received prior antibiotics. For suspected MRSA VAP, vancomycin or linezolid are often the go-to initial choices. It's worth noting, interestingly, that daptomycin, another strong anti-MRSA drug, isn't effective for pneumonia. It gets inactivated by pulmonary surfactant, the substance lining the air sacs in the lungs.
Oh, that's a specific detail. Good to know. And then there's the dreaded Clostridium difficile, or C. diff. What makes that one so challenging in hospitals?
C. diff. Clostridioides difficile infection, or CDI. It's strongly linked to recent antibiotic use. The antibiotics, while fighting one infection, can unfortunately wipe out the normal protective gut bacteria, allowing C. diff spores, which are often present harmlessly, to germinate, multiply, and produce toxins that cause severe diarrhea and colitis.
So antibiotics themselves are the main risk factor.
Often, yes. Certain antibiotics carry a higher risk than others. Fluoroquinolones, clindamycin, broad-spectrum cephalosporins, and carbapenems are often cited as high risk. Treatment primarily involves stopping the offending antibiotic if possible and starting specific therapy against C. diff. Oral vancomycin or fidaxomicin are now the preferred first-line treatments for most cases. And for patients who've had CDI before, avoiding high-risk antibiotics in the future is really crucial. Careful antimicrobial stewardship, choosing lower-risk options like maybe doxycycline, trimethoprim sulfamethoxazole, or macrolides when appropriate, is key to preventing recurrence.
It really hammers home that double-edged sword of antibiotics lifesavers, but they can also create new problems. Okay, moving from the hospital setting, let's explore infections in the immunocompromised host. This must be a whole different ballgame when the body's defenses are down.
It absolutely is. Patients with weakened immune systems may be due to chemotherapy for cancer, organ transplantation, or advanced HIV/AIDS. They become susceptible to opportunistic infections.
Meaning infections that wouldn't normally bother a healthy person.
Exactly. These are microbes that our immune system usually keeps in check easily, but they can cause serious disease when the defenses are lowered. For instance, neutropenic fever. This is common in cancer patients after chemotherapy when their neutrophil count, a key type of white blood cell, drops dangerously low. It's considered a medical emergency.
What's the approach?
Immediate empiric antibiotics are critical, usually starting with a single broad-spectrum beta-lactam antibiotic that has good activity against Pseudomonas aeruginosa, a common and dangerous bacterium in this setting. Something like cefepime, piperacillin tazobactam, or carbapenem. Interestingly, vancomycin, which covers MRSA, isn't usually started automatically unless there are specific indications like signs of severe sepsis, known colonization with MRSA, or a suspected central line infection. You try to avoid overuse.
Okay, so it's about acting fast and broad, but still strategically. For HIV specifically, you mentioned CD4 counts before. They act like a roadmap for vulnerability, don't they?
That's a perfect way to put it. CD4 T-cell counts are critical markers in HIV care. They really do act as a roadmap, predicting the risk of specific opportunistic infections at different thresholds. For instance, prophylaxis, that's preventative treatment for a pneumocystis jirovecii pneumonia, or PCP, is strongly recommended when the CD4 count drops below 200 celsum.
And what's used for that?
The drug of choice is usually trimethoprim sulfamethoxazole, often taken daily or 3 times a week. Then, if the CD4 count falls below 100, and the patient also tests positive for Toxoplasma gondii IgG antibodies, meaning they've been exposed in the past, prophylaxis against toxoplasmic encephalitis is typically added, often using the same drug, trimethoprim sulfamethoxazole.
And even lower counts bring other risks.
Yes. When the CD4 count drops below 50, the risk for Mycobacterium avium complex, or MEC infection, increases significantly. Prophylaxis, usually with azithromycin once weekly, is generally recommended at that point.
It's like peeling back layers of immunity, revealing new vulnerabilities. What about this thing called immune reconstitution inflammatory syndrome, or IRIS? That sounds kind of paradoxical.
It really is a fascinating and sometimes tricky phenomenon. Iris can happen weeks to months after an HIV patient starts effective antiretroviral therapy, ARKI.
So it happens when they're getting better.
Exactly. As their immune system starts to recover and get stronger thanks to the ART, it can suddenly wake up and mount a really vigorous, sometimes overwhelming inflammatory response against a pre-existing infection. This might be an infection that was already being treated or even one that wasn't causing any symptoms before because the immune system was too weak to react to it, like latent TB or certain fungal infections.
So the recovering immune system actually makes things seem worse temporarily.
It can, yeah.
Mm-hmm.
The symptoms are driven by the inflammation itself. Usually the RT can be continued while you focus on treating the underlying opportunistic infection more aggressively. Sometimes, though, corticosteroids might be needed for severe iris cases to help calm down that excessive immune response.
Wow. The body is just endlessly complex. Okay, shifting gears again. Let's think about our global village, global travelers and unseen vectors. Things like tick-borne diseases seem to be a growing concern in many areas.
Yes, definitely. Lyme disease, which is transmitted by the Ixodes scapularis tick, the deer tick, is probably the most well-known. Characterized classically by that bullseye rash, erythema migrans, but it's crucial to know it can progress if not treated early. It can lead to things like joint pain, Lyme arthritis, heart problems like AV block, Lyme carditis, or neurological issues like facial nerve palsy, Ball's palsy. Doxycycline is a first-line treatment for most stages.
And one tick bite can give you more than just Lyme.
Unfortunately, yes. That same tiny Ixodes hic can be co-infected and transmit other diseases at the same time. It can carry babesiosis, caused by a parasite that infects red blood cells. This causes a flu-like illness, often with hemolytic anemia where your red cells are destroyed. It can be particularly severe in people without a spleen, the elderly, or the immunocompromised. And it can also transmit anaplasmosis and ehrlichiosis, which are bacterial infections causing flu-like symptoms, often with characteristic drops in white blood cell counts, leukopenia, and platelet counts, thrombocytopenia.
So you have to think about multiple possibilities from one bite.
You do, especially in endemic areas.
Yeah.
Doxycycline, interestingly, treats not only Lyme, but also ehrlichiosis, anaplasmosis, and another well-known tick-borne illness, Rocky Mountain spotted fever. Babesiosis needs different treatment, usually a combination like ativaquone and azithromycin.
It's like one tiny tick can carry a whole cocktail of trouble. Okay, and for people actually traveling the globe, what major illnesses should be on their radar when they come back feeling unwell?
For global travelers returning with fever from endemic regions, malaria is always a huge concern. Classic symptoms include cyclical fevers, chills, sweats, headache, muscle aches, sometimes anemia, and an enlarged spleen. Diagnosis is still often made the old-fashioned way, by looking for the parasites on a peripheral blood smear under a microscope. Prompt diagnosis and treatment are critical. Dengue fever is very common in tropical and subtropical areas worldwide. It's infamous for causing severe muscle and joint aches, hence the nickname breakbone fever. Other signs can include high fever, headache, especially pain behind the eyes, rash, and often low platelet counts, which can lead to bleeding issues in severe cases. Chikungunya fever, another mosquito-borne virus, shares some features with dengue, like high fever and rash, but is particularly known for causing severe, often debilitating polyarthralgias pain in multiple joints that can sometimes persist for months or even years.
Wow, chronic joint pain from a virus.
Yeah, it can be quite disabling for some. And then there's typhoid fever, caused by Salmonella typhi, usually contracted from contaminated food or water in areas with poor sanitation. It typically presents with a gradually rising, sustained fever, abdominal pain, headache, and sometimes a characteristic faint rash of pink spots on the trunk called rose spots.
That's quite a list. Knowing what to suspect based on travel history and symptoms seems vital.
Absolutely crucial for getting the right diagnosis and treatment quickly.
Okay, finally, let's briefly touch on beyond the everyday. Some of these are rare but incredibly significant infections, maybe things like bioterrorism agents.
Right. This category includes potential bioterrorism agents like anthrax, plague, and smallpox. Even a single suspected case of these would trigger a massive public health investigation and response due to the potential for rapid spread and high mortality. For example, inhalational anthrax, while thankfully very rare, is highly lethal. It might initially present just like the flu, with maybe some chest pain, but a key finding on chest X-ray can be a widened mediastinum, the space between the lungs due to hemorrhagic lymphadenitis. Recognizing these rare possibilities is important.
And fungal infections. They seem diverse, too.
Very diverse. Fungal infections range from the extremely common, like candida infections causing thrush or vaginal yeast infections, all the way to life-threatening systemic candidemia, which is candida in the bloodstream. Systemic candidemia often requires prompt removal of any central venous catheters and treatment with powerful antifungal drugs, like echinocandin empirically. Then you also have the endemic mycoses. These are fungi that live in the soil in specific geographic regions. Examples include histoplasmosis in the Ohio and Mississippi River valleys, blastomycosis in the eastern and central U.S. and Canada, and cogidioidomycosis, or valley fever, in the southwestern U.S. and parts of Central and South America.
And they cause different problems.
They can cause a wide spectrum of illness, from asymptomatic infection or mild flu-like illness to chronic pneumonia, or even severe disseminated disease spreading throughout the body, especially in immunocompromised individuals. Diagnosis often involves specific antibody tests, antigen tests, or fungal cultures.
It's truly incredible, the sheer variety of microscopic threats out there, from the mundane to the truly exotic or rare. And all of this kind of leads us to the evolving antibiotic landscape. This really feels like a constant race against time, doesn't it?
It absolutely is. And it's arguably one of the most critical challenges facing modern medicine today, the rise of antimicrobial resistance. We do have newer anti-infective therapies coming out, which is good. Drugs like daptomycin for certain MRSA infections, or ceftaroline, cephalosporin that actually has activity against the MRSA. These are valuable additions to our toolkit.
But new drugs aren't the whole answer.
Not by themselves, no. The overarching principle, the thing that's truly essential to preserving the effectiveness of all our antibiotics, both old and new, is antimicrobial stewardship.
Stewardship, meaning using them wisely.
Exactly. Using antibiotics judiciously. That means choosing the narrowest spectrum agent possible, the drug that targets the specific bacteria causing the infection, without blasting everything else. It means de-escalating therapy, switching from a broad-spectrum empiric drug to a more targeted one, once culture results identify the specific bug and its sensitivities. And it means ensuring the proper duration of treatment, not too short, but also not unnecessarily long.
Because overuse drives resistance.
Precisely. Suboptimal use, overuse, unnecessary use, all of these practices put selective pressure on bacteria, allowing resistant strains to emerge and spread. And resistance to major threats like MRSA, ESBL-producing gram-negatives, VRE, vancomycin-resistant enterococci, and carbapenem-resistant organisms is a growing global crisis. Stewardship is our main strategy to fight back and preserve these precious resources.
Wow. What a journey we've just taken. We've really covered an incredible landscape, haven't we? Highlighting how every patient's specific context, their age, their immune status, where they've traveled, even what medical procedures they've had, can just dramatically shape which infections they're susceptible to, how they present, and what the best treatment is.
Yeah, it really has. And this whole deep dive, I think, has underscored that critical interplay between rapid diagnosis, getting the right targeted therapy, and also vigilant prevention.
That theme of urgency really came through again and again.
It really did. We saw how acting quickly, often needing to start with those empiric broad-spectrum antibiotics based on suspicion alone, can be absolutely life-saving in situations like bacterial meningitis or febrile neutropenia in a cancer patient, or that scary necrotizing fasciitis. Time is tissue, or time is brain in many cases.
And also the constant evolution on the diagnostic side, moving from traditional cultures, which still have their place, to these incredibly sensitive PCR tests and antigen tests.
Right. Which is powerful, but as you said, it also brings challenges, doesn't it? Interpreting those results correctly, especially maybe early in an illness or when you get an unexpected positive, or even dealing with potential false positives or negatives, it's not always straightforward.
No, definitely not. And we really hit hard on antibiotic resistance. It's not just some abstract future threat. It's here. It's now.
It absolutely is. And that's why prudent antimicrobial stewardship, de-escalating therapy when you can, choosing the narrowest effective drug, ensuring the right duration, it's not just nice to have, it's essential. It's our lifeline, really, to preserve our ability to treat infections caused by bugs like MRSA, ESBLs, VRE, all of them. It's a responsibility for every single prescriber.
And let's not forget the flip side, the power of prevention, the unseen protectors.
Yeah, that's a great way to put it. The profound impact of vaccines. Routine flu shots, pneumococcal vaccines, and also specific prophylaxis strategies. Things like HIV pre-exposure prophylaxis, PPP, or post-exposure prophylaxis, PBP. These proactive measures prevent just an immense amount of suffering and disease. It really shows the power of foresight in public health.
Absolutely. And finally, I think this discussion really hammered home how connected our world is now.
Definitely. Global travel, Environmental changes. They bring diseases that once seemed distant, like dengue or malaria, or even something like neurocysticercosis from tapeworm larvae, right to our local clinics and hospitals. It's a stark reminder that really no infection is truly isolated anymore. We're all in this together, globally.
Well, we really hope this deep dive has given you, our listeners, a newfound appreciation for this incredibly complex world of infectious diseases, hopefully equipping you with some valuable insights that maybe go beyond just the headlines and get into the intricate details that truly matter in understanding these challenges.
Yeah, hopefully it sparks some curiosity too.
For sure. And maybe a provocative thought to leave you with. As we keep pushing the boundaries of medicine, with new therapies, new diagnostics, what do you think will be the next major unmasking in infectious diseases? Will it be a completely new pathogen emerging, a novel, unexpected mechanism of antibiotic resistance, or maybe a breakthrough in how we understand our own immunity that completely redefines how we protect ourselves from these unseen threats?
That's a great question. Constant vigilance and research are key.